Today I'm here to present a case which was done in Kamalnayan Bajaj Hospital on Pheochromocytoma. So as the name suggests, from crisis to control, the navigation, anesthesia in Pheochromocytoma. This case took us from crisis to control, and this case was challenging, and this was managed under the expert guidance of Dr. Balaji Asekakar sir, whose clinical judgment and meticulous planning were pivotal in the outcome of this case. So, coming to the case presentation, a 40-year-old female came with the complaints of intermittent headache, palpitations, nausea, and vomiting since 4 months, and she was diagnosed case of hypertension since 4 months. She was started on tablet prazosin 2.5 mg OD and tablet metexel 25 mg OD. So, in the past history, this patient had undergone laparotomy with a portion of suprarenal gland removal was done on 5th March 26. The procedure was abandoned in view of very fluctuating BP and in view of risk of major vascular injury, unavailability of vascular surgeon. This patient was kept in ICU for 2 days and then she was discharged stably on 10th of March 2026. On investigations after the case notes seeing the urinary VMA, which was the key marker, that was increased to 4 times the normal. And the VMA creatinine ratio, the normal ratio is around less than 7. This was also elevated, which confirms that there was a catecholamine hypersecretion. The other hormonal profile of this patient was normal, and 24-hour urinary metanephrines were also normal. On examination, the vitals were pulse rate of 88 per minute, BP 120/70, and saturation of 100% on room air. Systemic examination was normal. In per abdomen, there was a previous scar mark of the surgery. So the diagnosis summary was 40-year-old female, hypertension with hormone secreting paraganglioma of right adrenal gland. This was labeled under ASA grade 3, and the surgery was posted on 7th of April 2026 in Kamalnayan Bajaj Hospital. In the preoperative assessment, so the patient was personally seen by Dr. Balaji sir, and it was beautifully planned and managed throughout. So coming to hematology and biochemistry of this, the labs were CBC were normal, HbF 11, TLC 6400, platelets 2,87,000, creatinine, KFT, serum electrolytes, INR were normal, blood group was B positive, and HbA1c was normal. There were no raised sugars. Cardiac evaluation, in ECG, there was sinus rhythm, no ECG changes, and 2D echo, left ventricular ejection fraction was 60 to 65%, concentric LV hypertrophy, and grade 1 diastolic dysfunction. Imaging, the CT abdomen suggested of right suprarenal mass of 5.8 by 3.5 by 5.9 centimeter. There was IVC severe compression was there, and there was IVC infiltration. This was the major concern from the surgeon point of view, that it was closely adhered to IVC. On histopathology, was suggestive of paraganglioma, and parathyroid hormone was normal. So in the preoperative preparation and pre-induction checklist, coming to the patient preparation, the high-risk consent was taken. The morning dose of antihypertension drug, prazosin and metexil was taken, was confirmed. As the surgery was planned at 7 a.m., it was made ensure that patient has taken the tablets by 5:30 a.m. in the morning. And the BSL was checked before shifting to OT, which was 128, and post-op ICU and bed venti support needed was confirmed. In the drug preparation, we have kept all the drug ready as advised by sir. NTG infusion, magnesium sulfate was kept, esmolol, vasopressin, noradrenaline, hydrocortisone, and injection metoprolol. Under the emergency drugs, atropine, adrenaline, calcium gluconate, soda bicarb, amiodarone, and defibrillator was confirmed, charged, and ready. Blood products, 4 units of PRBCs, FFP, and platelets were confirmed. Their availability was confirmed. So, intraoperative anesthesia management, we have induced this patient thoracic epidural and general anesthesia combined technique. In pre-medication, we have given injection Midas 2 mg and injection Fortmin 30 mg. At the induction, we have used injection Propofol 100 mg and injection PEG 8 mg. Induction was done very smoothly to avoid the raise in BP and to avoid hypertension. So the lines and access established. The right IJV was cannulated by 7 French CVP catheter, and CVP line was attached, which was the CVP recorded was 6 to 8 mmHg. The right radial artery was cannulated and invasive BP monitoring was attached. The BP was 120/70 mmHg. Large bore left peripheral IV line was taken 18 gauze. The drugs which we have used for BP control in this patient were we have kept the injection magnesium sulfate, and during the intraoperative procedure we have given magnesium 4 grams slowly in 100 ml. Injection NTG was titrated according to BP, and injection metoprolol was used. We have also used injection dexmedetomidine around 20 microgram. For the pain management of this patient, injection fentanyl was given before incision 100 microgram and afterwards as needed. Injection tramadol was given to the patient. We have also used injection paracetamol, and intermittent epidural top-up was given. So during the whole intraoperative procedure, as the surgeon was handling the tumor, the BP was changing. There was high fluctuations in the BP. So what we have recorded, the lowest BP was 70 by 40 mmHg to maximum of 300 by 150 mmHg throughout the procedure. So there were spikes with every tumor manipulation. We have done continuous CVP, and urine output was monitored. The temperature probe was attached, and fluid warmer and body blower was also attached to maintain the temperature of the patient. So as the BP was fluctuating, we have asked the surgeon to stop the handling for a few seconds, and we have increased the NTG, and we have brought down the BP to normal range. And then after the ligation and excision of the tumor, there was sudden BP fall. The BP fall was extreme, and this was the last recorded BP was 70 by 40 mmHg. This was managed with fluid challenge. Firstly, we have given 500 ml of fluid bolus, and then we have started injection NORAD infusion. So this was also titrated according to BP. So these are the photos which shows the tumor is very closely adhered to IVC, and whenever the surgeon was handling the tumor, there were rise in BP. So this is the specimen which was taken out. The next slide shows the highest BP recorded 288 by 170, and CVP was around 11 at that time, and the lowest BP was 78 by 40. So coming to the extubation, before extubation at the end of surgery, there was persistent hypotension. But apart from hypotension, there was disproportionate rise in CVP, which was noticed by biology sir. The CVP was raised to 16 by 18 mmHg. So sir has decided to transthoracic echocardiography. After doing it, we have noted that there was anterior wall hypokinesia was present. So and the IVC was checked, which was full around 1.5 centimeter. So at this stage, we have restricted the IV fluids, and the injection NORAD support was increased from 3 ml per hour to 6 ml per hour. And here we have kept the injection adrenaline infusion ready. After this, we have given injection Lasix 20 mg to the patient. After some time, we have extubated the patient injection with injection Sogammadex, and she was on NORAD support. And then we have shifted the patient to ICU on face mask. So on the basis of transthoracic echocardiography findings, the cardiologist reference was given. Cardiologist did echo, and the cardiologist labeled it as stress cardiomyopathy. So these were the notes of the cardiologist. In this, the first ECG shows the normal ECG sinus rhythm before the operation, in the pre-op period, and the next ECG, which shows the T inversion from V2 to V5, mostly all the leads. This was seen after, as soon as we have shifted the patient to ICU, the ECG was done, and then cardiologist did echo and ECG. So they have labeled that the ejection fraction was 45 to 50% with generalized LV hypokinesia, mainly apical, and ECG T inversion in all lead. So they have advised the cardiac biomarkers. After doing the cardiac biomarkers were normal. So this patient was managed in ICU under cardiologist, and then inotropes were slowly tapered off, and patient was shifted to ward after 72 hours. So preoperative alpha blockade protocol. In this, the alpha blockade must precede the beta blockade. So a beta blockade without prior alpha blockade, there is unopposed alpha receptor stimulation, which may lead to severe hypertensive crisis and peripheral ischemia. The drug of choice or gold standard in this is phenoxybenzamine, and it is non-selective alpha blocker, which has to be started preoperatively in pheochromocytoma patient. But this has complication of orthostatic hypotension. So it causes orthostatic hypotension. In this case, the drug used was prazosin, which is selective alpha-1 blocker, and it is shorter acting and better tolerated with less reflex tachycardia. The beta blocker which was used in this case was metoprolol, and it controls tachycardia and dysarrhythmias and never start before alpha blockade. So intraoperative hypertensive crisis, in this the management algorithm, the trigger is that systolic BP more than 160 mmHg or any acute rise more than 30 mmHg from baseline. So pause the tumor manipulation first. Stop tumor manipulation. The surgeon is asked to stop as soon as the BP rises. We have asked the surgeon also to stop for a few seconds or minutes, and then we have increased NTG, and then the BP was under our control. Then second point is the deepen the anesthesia to increase the volatile anesthetic agents and make sure the patient is adequately relaxed. The third is the NTG. We have started the NTG infusion. NTG has helped. And the fourth drug which was used was magnesium sulfate. So magnesium was given to 4 gram over 10 to 15 minutes, and which inhibits catecholamine release, and it has brought the BP down. Thus, we have kept the sodium nitroprusside infusion ready, but in this patient we have not used sodium nitroprusside. We have managed the case with NTG, magnesium, and metoprolol. And next is the we can use esmolol to prevent tachycardia, and last is the metoprolol. Intraoperative hemodynamic management. In this critical challenges, there are two phases in this. First phase, there will be extensive hypertensive crisis, or there will be extensive hypertension. And after the ligation and the removal of the tumor, there will be profound hypotension. So these two things we have to manage in this case. The increase in the hypertensive crisis management can be done using sodium nitroprusside, NTG, esmolol, which is a beta blocker, magnesium sulfate. In the hypertension management, we have started after the ligation and excision of the tumor, there was a drop in the BP, there was hypertension. So we have started the patient on noradrenaline. We have kept vasopressin, phenylephrine ready. So corticosteroids plays major role in the bilateral adrenalectomy. So if the adrenal insufficiency is suspected, so the corticosteroid should be given, and the aggressive intravenous fluid management should be done. The intravascular volume is in contracted state, so preloading the patient with the fluids is very important. So we can preload the patient with colloid and crystalloid before tumor devascularization. The target CVP should be kept around 8 to 12 mmHg, and albumin can be used for oncotic support. We have also reserved the PCV, platelets, and FFP in this patient. Now coming to pheochromocytoma. So pheochromocytoma is catecholamine-secreting tumor which arises from the chromaffin cells of the neural crest origin. So the rule of 10 in this is that the 10% patient are intra-adrenal. The most common site is at the organ of supracondyle, which is at the aortic bifurcation. Then 10% occur in children, 10% are familiar, 10% bilateral or multiple, 10% recur, and 10% malignant, and 10% are discovered incidentally. So these pheochromocytoma can also be associated with some syndromes like von Reckling-Hausen syndrome or MEN 2A and 2B and neurofibromatosis also. So the coming to signs and symptoms, the 5 Ps, that is the pressure, which is hypertension, pain, headache, and perspiration, that is increased sweating, palpitation, and pallor. Pallor is due to adrenergic response. There will be paroxysms, the 6P. Headache will be paroxysmal mostly or maybe continuous. The catecholamines are secreting continuously. So the classical triad for the diagnosis of pheochromocytoma is the headache, which is the most common symptom, then perspiration, sweating, and palpitations. The hyperadrenergic manifestations, which include hypertension, palpitations, panic attacks in patients with tumors which produce an increase in epinephrine. There may be increase in BMR, which may lead to weight loss. Due to very high release and catecholamines, there can be tachyarrhythmias like atrioventricular tachycardia, AF, and atrial flutter. There may be tremors if the beta-2 receptor in the muscle is responsible for tremors, and only at peaks of catecholamines there will be tremors will be available. So the pheochromocytoma crisis or paroxysmals or spells, in this the triad is the same: headache, most common, perspiration, sweating, and palpitation. So catecholamines have t-half of 10 to 60 minutes. So there are episodic hypertensive spikes. The frequency may be daily to monthly. There can be also spontaneous, continuous secretion of catecholamines. So it can be episodic or it can be spontaneous. So this catecholamine secretion is precipitated when we are doing any diagnostic procedures or due to some drugs like opioids or unopposed beta blockade. During anesthesia induction, there will be, if the induction is not done smoothly, there will be increase in catecholamine secretion, which may lead to increase in BP. So histamine releasing drugs to be avoided, and ACTH, glucagon, and metoclopramide to be avoided in these cases. So the strenuous exercise and the movements that increases the intra-abdominal pressure, like while palpation of the tumor, there may be a release of the catecholamine, which may lead to increase in BP. The micturition and straining at defecation also. So the signs and symptoms, again, there can be nausea and vomiting, abdominal pain, severe constipation, which is alpha-1 mediated intestinal relaxation. Chest pains may be there, anxiety, angina or MI with normal coronaries. Catecholamine causes the coronary vasoconstriction, which may lead to increase in myocardial oxygen consumption and which may lead to MI. So in the congestive heart failure, due to continuous hypertension, there will be hypertrophic cardiomyopathy, which may lead to diastolic dysfunction. The catechols induced dilated cardiomyopathy can lead to systolic dysfunction. So cardiac dysarrhythmia, and there may be conduction defects also. In the metabolic, there is mild glucose intolerance due to increase in catecholamines and lipolysis. So it will lead to weight loss, ketosis. There may be hypercalcemia, mostly seen in MEN2 syndromes. Coming to the main point in this, so what sir has ruled out that the patient was, before the surgery, the 2D echo of the patient was normal. The left ventricle ejection fraction was around 60%, and there was grade 1 diastolic dysfunction and concentric LV hypertrophy. But as there were many BP fluctuations, and after the what we have noticed that due to massive catecholamine surge during tumor manipulation, or maybe due to activation of beta-1, alpha-1 adrenoreceptors, which caused calcium overload, the microvascular spasm or subendocardial ischemia, or contraction band necrosis. This can be pathophysiology, which caused stress cardiomyopathy during surgeries. So the stress cardiomyopathy, in this, we have ruled out the stress cardiomyopathy intraoperatively in this case. It was due to intraoperative catecholamine release. So the pathophysiology of this is that there was massive catecholamine surge during the tumor manipulation. So the BP was raised from 300 to 170. Then under the pathophysiology, it can be due to activation of beta-1 and alpha-1 adrenoreceptors, which is due to calcium overload. It can be due to microvascular spasm, that is subendocardial ischemia, and contraction band necrosis. So the clinical features which is related to stress cardiomyopathy is that there can be acute LV systolic dysfunction. Previously, there was no systolic dysfunction in this patient and the ejection fraction was normal. So due to stress cardiomyopathy, which was due to increase in catecholamine levels, the EF was reduced, and the next is the hypertensive crisis and flash pulmonary edema. The ECG shows ST changes, T waves inversions, and QTC prolonged. The troponin and BNP elevation can be there. There may be arrhythmias, VT and VF, AF, and sinus bradycardia. So, how to manage this stress cardiomyopathy is that the use of inotrope to maintain contractility, optimize hemodynamic, and avoid fluid overload in this patient, as we have avoided the fluid overload after doing the TTE, and avoid sympathetic activation. The key learning points to be taken from this case of pheochromocytoma is that the alpha blockade should be first. It is establish adequate alpha blockade, phenoxybenzamine or prazosin, as prazosin was used in this case, before beta blockade to prevent unopposed alpha agonism. And invasive monitoring is must. We have taken CVP line and arterial line so that the BP can be monitored step bit to bit. And third, that if the IVC was involvement was there in this case, so the further preparation was needed. So we have kept the blood and blood products ready. Surgeons have asked the vascular surgeons to be called if needed, and we have also kept colloids and crystalloids ready. So fourth is the aggressive bit management of hemodynamics is needed. Fifth is the epidural analgesia. The thoracic epidural, it reduces the sympathetic outflow, blunts the hemodynamic responses, and provides excellent post-op pain control. And sixth and last point is the ICU is mandatory. So all pheochromocytoma surgery should go to ICU for 24 to 48 hours for BP management, hormonal surveillance, and glucose monitoring. So the take-home message in this case is that successful anesthetic management of pheochromocytoma hinges on meticulous planning, effective team coordination, and real-time integration of physiology and pharmacology. So pheochromocytoma is very challenging for anesthesiologists, and your preparation and high index of suspicion decides the outcome. So stress cardiomyopathy is very underrated condition, and it requires high index of suspicion as managed by biology as it occurs. So thank you so much.